And with that, it gives me great pleasure to introduce today's speaker, Jan Lind, who is the co-nursing lead for the neonatal neurocritical care program in Calgary, Alberta. Jan has 25 years of experience in neonatal intensive care. She's trained in London, England, but has lived and worked in both the United States and Canada for over 20 years. Her career has encompassed a strong clinical background in the NICU, working as staff nurse, clinical nurse educator, high-risk transport nurse, and nurse clinician. She has special interest in neonatal neurocritical care. Jan is the co-lead for the nursing neurocritical care program in Alberta Children's Hospital, Canada, and was involved in development of the neuroprotective care bundle for the management of infants with HIE. She is also the co-chair for the Parent Partnership in Care Committee and is a strong advocate for family integrated care. When she is not working, she lives in her busy household of two beautiful girls, two crazy dogs, two noisy parrots, one happy rabbit, and one husband, prioritized in that order. And one last thing about Jan, the unique thing about her is her passion and dedication. It's hard not to be infected by her passion, and she always encourages you to step out of your comfort zone. So Jan, it's very good to have you with us today.
Good morning. Thank you so much, Khorshid. Well, I'd like to say hello to everybody and thank you for this opportunity to share our model of neuroprotective nursing care here at Alberta Children's Hospital in Calgary, Canada. Before I start, I'd also like to acknowledge the information sharing and networking inspiration that Kathy Sally Randall has provided through our annual One Conference's online neurocritical teachings, which have definitely had a far-reaching effect, even all the way to Canada, and help guide our initiatives and support some of our nursing practice guidelines here in Alberta. So thank you so much, Kathy. So the title of my talk is Neuroprotective Nursing Care, More Than Just a Cool Cub. So the objectives of today's talk are to understand the concepts of neuroprotective care that relevant to an infant with a potential injured brain, to identify the components of our neuroprotective bundle for neonatal hypoxic ischemic encephalopathy, which we like to call our hibernation protocol, and to recognize and acknowledge the impact that nursing care can actually have on improved outcomes. I have no disclosures, apart from the fact that I'm just a little bit afraid of bears. So what is neuroprotective care? Neuroprotective care involves a process and strategies used to protect against neuronal injury or degeneration of the central nervous system. It limits the damage of an acute injury and optimizes cellular function to improve both short and long-term neurological outcomes. And essentially, it encompasses all interventions that really help promote normal brain development. So studies suggest that the unique physiological state of hibernation can provide several neuroprotective strategies. So here at Children's Hospital, we took this concept and tried to make things a little less scary and more comforting for families, and likened the therapeutic hypothermia treatment of the baby to a little bear going into a state of hibernation, entering a short 72-hour winter sleep. Parents receive one of our teddy bears, a cool cub, and get to keep the brain net, which we use to guide our EEG electrode placement, as a memento of their time in the NICU. This approach really seems to help parents cope with the unnatural feeling of their baby's body temperature being cooled. So a few fun facts about bears. During hibernation, their body temperature drops to about 7 or 8 degrees. The heart rate slows to from 50 to about 2 to 10 beats per minute. They can suppress the metabolism by about 75%. And in those fat rolls, they store about 1 million calories. So bears are actually awake in a reduced metabolic state called a torpor that significantly reduces their oxygen consumption. So extreme caution needs to be used when you come across a hibernating bear. If you wake them suddenly, you can put them into a cardiac arrest, or worse still, you'll have a really angry bear on your hands. So remember, don't poke the bear. The same caution is needed for our cooled babies. We train our team to recognize when the baby is in a sleep state so that we are careful not to startle them, as the main goal of care is to keep them calm and reduce their metabolic needs. So what does hibernating in a neuro NICU look like? We developed the mnemonic HIBERNATE to help identify the priorities of neuroprotective care. Strategies are aimed at limiting damage or lessening the evolution of the insult, thus promoting the highest possible integrity of cellular function. And we'll go through the stages now. So hypothermia. Therapeutic hypothermia is the standard of care for those infants that meet the criteria for cooling. So the body temperature is rapidly cooled to 33 to 34 degrees. At ACH, we are a tertiary center for infants that are outborn. So cooling is usually initiated at level 1 or a level 2 center following consultation with our level 3 sites. Cooling is continued for 72 hours from the time that target temperature is reached. The beneficial effects of cooling are a decreased cerebral metabolic rate, which is reduced by 5 to 7% for every 1 degree drop in body temperature, reduced edema, hemorrhage, and neutrophil infiltration, a slowing down of brain cell depolarization, decrease in the accumulation of excitoamino acids, reducing intercellular calcium accumulation, a decrease in the rates of free radicals, protecting cells from oxidative damage during that reperfusion phase. And it also helps to maintain the integrity of brain cell membrane. Cooling the infant can prevent the evolution of the injury to cellular apoptosis or programmed cell death, but it can't really reverse the necrosis, recognizing that we can't reverse the damage that's already done. Therapeutic hypothermia is regarded as a safe procedure. There are some side effects, and I'll cover those later in the talk, but serious adverse effects are rare and are more likely due to the severity of the illness rather than the therapeutic hypothermia. So the next important strategy for neuroprotective care for the infant, and I love that this comes here because so often it is discussed at the end of all of our interventions, but so important to both the short-term and long-term outcomes of the infant, is the need for a family presence. For many of our families, it is an unexpected trauma, a healthy pregnancy where complications seem to arise at the delivery time. The journey has been described as this emotional roller coaster, a range of intense emotions from disbelief to guilt, hope, and ultimately we still have that uncertainty at the end of it. We don't always have the answers for our families. At this incredibly stressful time, families need information and open communication. An information brochure is given to our families by our neonatal transport team explaining the terms HIE and therapeutic hypothermia and why the baby needs to be cooled. Outreach education in our province has really helped rural teams identify early signs of encephalopathy, but has also provided them with a better understanding of our neuroprotective protocol so that they can prepare families for the treatment and care that they'll receive at the tertiary sites. Nurses are a significant source of support and have an important role in educating families about what to expect during cooling and their NICU admission. Communication needs to be honest, open, and compassionate. Consistent caregivers, so retaining the same nurse with the family as long as possible, can help to provide the continuity of care and familiarity and reassurances for families. We really want to involve parents, and we do in family rounds, and provide them with a 24-hour EEG update, whether there are changes or not, and they're spoken to every day by our neurocritical care team in neurology. We encourage and provide journals and diaries for families, and this is a way for families to express their emotions, write down questions, and just simply sort of gather their thoughts and kind of put everything into perspective. We also are very lucky here to have a Beads of Courage program. So families the baby gets a bead, which each bead has a certain meaning, and the beads become a reflection of their baby's courage and strength through their NICU journey. So parents need to be able to participate in the care of their infants. We know that parents that are involved in their baby's care have less stress, they feel more confident as their roles as parents, and they feel a greater sense of control. We let mums and dads get involved in giving oral immune therapy, so the EBM that mum expresses for comfort, and we use it for pain control too. They can participate in feeds, and they're encouraged and supported to be involved in any sort of general care of their babies, like diaper changes. Despite all the lines and tubes, we really want them to get in there and help with the care. We are lucky to have single patient rooms at the Children's Hospital, so it allows accommodation for one parent to sleep overnight, so parents can stay and be close to their babies. We know that newborns have a really acute sense of smell, and so studies have shown that odors form part of that complex sort of bonding process. And so we have what we call puggles, and these are two heart-shaped organic cotton cloths. Mums are encouraged to hold the puggle close to their skin or sleep with it so that it picks up their scent, so they can be left with the baby, and it has a calming, soothing effect. The puggle is a comfort for mum too, because it retains the smell of her little one, which also helps stimulate lactation. And as we know, breast milk is best for growing healthy brains. A study by Beatty in 2016 actually looked at even just the smell of maternal breast milk could help reduce and lower cortisol levels, and there was less crying during heel pokes. So it's incredible to think that even the smell of breast milk has an analgesic effect. Parents need to feel sort of part of the team with information and knowledge sharing. So we kind of involve them, expect them to kind of write down their questions and sort of guide them. And there's a lot of education around so they can feel that they are actually part of the interactive team and decision making. And they can be an advocate for their child. We know that mums feel both physically sometimes and emotionally traumatized. And there's a lot of evidence to say that depressed mums, can have an impact on the long-term development of the child. So it's important to acknowledge the stress and anxiety and optimize support. So there is early social work referral and early screening for postpartum depression and PTSD. We're lucky to have our own NICU social worker, and it's important to get them in contact with these families because it can be quite a traumatic event, as I said, for mum too. We also have a peer-to-peer support program through our peer mentorship program. They offer support from mums that have actually had similar experiences. We also have a family-to-family connections program, which offers peer support and so when families go home, they can have support, which is just a phone call away. So really important that we support sort of our families. It's important to remember that this is just the beginning of the journey. When we look and compare the data here in Calgary, Alberta, for babies born less than 29 weeks and infants with a diagnosis of HIE, our HIV babies have higher rates of severe cerebral palsy. Infants discharged with HIE are at higher risk for motor and cognitive impairment, as we know. So it's essential that we really build that confidence in our NICU families and parenting skills and support the parent bonding because there's a long road ahead. And often these families are with us for a very short space of time. It's also important to recognize that following these traumatic trauma events are not just that the families, as I said, are not with us for very long. And so we need to let them know that there will be sort of follow-up for them. Some families will need to be referred to physiotherapy, ophthalmology, referrals will be made, and so that we can really kind of generate the best outcomes for our little ones. Boundaries. So neurologically injured babies need supportive provisioning and to be able to maintain alignment and promote that safety control and physiological stability and support brain reorganization. This can simply be done by providing sort of boundaries, containment, supporting that flex position, preventing sort of extension, and really maintaining them in that midline position. This really helps them sort of gain state control. So we just kind of tuck some blankets underneath sort of the cooling mattress that we have and kind of really keep babies in alignment. The environment. So the environment is super important. And just really like when we're thinking about sort of preterm babies, we just have to try and keep these babies in a very calm state. The goal is if we have well-planned and coordinated activities so that we do avoid overstimulation. A reduction in stress environment can really help minimize that metabolic rate and prevent the risk of temperature elevation, increased intracranial pressure, and increasing metabolic demands for the brain. So we're going to look at noise v sound and lighting. So noise in the NICU comes from pages, pumps, phones. So we make sure that we put our pages on vibrate. We want to keep that sort of quiet zone, so less than 50 decibels, and so avoid sort of abrupt sort of clatters and noises. Turn our alarm volumes down as low as we can so that we can still hear them, so that it's still safe, but it's not obnoxious. And attend to sort of monitors and pumps alarms promptly so that it doesn't sort of startle the baby. This is also helpful for families as well because it reduces the stress, because when the alarms are going off all the time, it can be a real concern. Because we know that cooling can drop the baby's heart rate down into the 70s or 80 beats per minute. And so we really want to make sure that we attend to those alarms promptly. Loud conversations go outside the room. When the baby is transferred in by the transport team, we try and have a handover outside of the room. But we know that a conversational voice is really important for these little ones. So there's a difference between obnoxious sound and positive sound. So a quiet conversational voice is comforting and enriching for the baby. And hearing a mother's voice really enhances that bonding and attachment and can be a real comfort. Studies have shown that low intensity recorded maternal voices can lead to positive physiological responses, definitely in preterm babies with an increased in oxygen, and I think we know this anecdotally when we see our babies when the mums come in, and a decrease in the heart rate and the rest rate. And so really important that mum feels that she can speak to her baby. Shared reading has also been seen that it's really important to start as soon as possible for babies, because it has long-term cognitive, social, emotional, and neurological and neurobiological benefits for the baby. Long-term, it has been shown to have increased language development, reading, and improved literacy. At Children's, we have a Books for Babies program, and we encourage parents to read to their children for at least an hour a day. And even when the babies are requiring neurocritical care, quiet storytelling as a peaceful and comforting is peaceful and comforting for the child. If mums and dads are there, it gives them something to do. And also we know that there is kind of voice recognition for the child, because that separation can be really, really stressful. If you don't have a mum or dad there, or if they can't be there, then you can always get your French neonatologist dressed in a kangaroo suit to help you out. And later, as the baby starts to sort of wake up from their sleep, then we sort of encourage that dialogic, or that what we call interactive reading, which is so important. So when during that recovery phase, in that post-rewarming, this is where we use kind of eye contact, a mother language, where we use intonation in our voice, we're a little bit more animated, and we have that joint attention. So we're sort of speaking to the baby, and we're talking in that high-pitched tone that we do, that's a very sort of non-threatening kind of voice, and we give positive touch. And interestingly enough, functional MRIs have indicated that the white matter tracts in the brain become more organized in children that actually listen to stories. There is an increased blood flow to the visual cortex in the cortex region of the brain. Why the visual cortex, you might ask? Well, it turns out that positive sound simply ignites the imagination. Now, I'm not really sure what babies actually see in their imagination. Maybe just, I know they're always looking for their mother. So the neuroprotective environment calls for initially sort of that sort of indirect and kind of filtered lighting, where we can keep the baby in that calm state. We want to cover the baby's eyes with soft cloths when we're doing procedures, to avoid that examination light shining in their eyes, just really to maintain comfort and not cause any distress. But it's really important, and sometimes we see this, that babies have kept in the dark, and then 7 days later they're still sitting in the dark. So it's really important to kind of normalize that and gradually bring light back into their life. So once we've sort of discontinued the EEG, and sort of if they're sort of out of that sort of quiet, very calm state, then we really want to kind of reset their circadian rhythms and sort of bring them back into the world, and allow them to sort of normalize. Rest, recovery, and recognition. So it's important to be able to recognize sleep-wake patterns on EEG. So scheduled caregiving can be adapted to the infant's sleep-wake cycle, which it's really difficult to assess a baby that's sedated or encephalopathic and lethargic to know when they're sort of really kind of sleeping. Studies in Thorson have sort of indicated that recovery of the sleep-wake cycle in a non-cooled baby with a good outcome happens usually within sort of 24 hours. But it's recognized that babies that are cooled, the recovery of the sleep-wake cycle might take a little bit longer, up to 48 hours, and an even recovery of that sort of normal sort of background pattern. But we do know that failure of evidence of a sleep-wake cycle to return is still associated with those poor neurological outcomes. So we train our nurses to recognize that, and then not go in and startle the baby when the baby is in that sort of deep sleep. So when that sleep-wake cycle comes, we try and avoid it. Avoid sort of disturbing them. And so our goal is to avoid disrupting that sleep. We know that sleep plays a really important role in synaptic development, learning, and memory. And it's a time of reorganization for the brain. And as I said, it's a really important indicator of brain health when they develop that organized sleep-wake cycle, and a sign that the brain is recovering, and recovery of the neurons too. Gentle handling is always important because it promotes that calm, kind of nurturing environment. And so we really want sort of intentional nursing. We really want people to understand that this little one's been through a little bit of a trauma. And so just be very sort of kind and intentional in the care that we provide. And again, don't startle that little bear, because when we startle them, we get that disorganized brain activity if they're woken up very abruptly from their sleep. Nutrition. So in Alberta, in the Rocky Mountain Provincial Parks here, there are many signs up saying don't feed the bears. But that's not the case for this little cub. So during hibernation, we do actually start a trophic feed. So trophic feeds for us are started at 24 hours of age, just about 1 to 2 mils per kilo every 3 hours. And we do this when the lactates have returned to a normal range, so when they're a little bit less than 2. And we continue trophic feeds for 72 hours or until hypothermia treatment is complete. We recognize that fresh EBM is preferable and not frozen and not refrigerated. So as soon as mum's pumped it, then we ask her to kind of bring her milk in, or if she's obviously there, then she can provide it with us. Stem cells in human breast milk are pluripotent, meaning that they have the ability to differentiate in other cell types, including neural-like cells. So a lot of study into that now, and we know that stem cells are destroyed in frozen milk. So we try to avoid, if we have to, we will give some or donor human milk, but in preference we like the fresh, and we avoid using formula. Evidence to and research by Thyroidogen, I can never say that name, really sort of supported our sort of decision to go ahead and sort of have those minimal enteral feeds. They did a retrospective cohort study and looked at units in the UK and Sweden, and they sort of initiated minimal enteral feeds, and they found that in minimal enteral feeds initiated for moderate to severe HIE infants did not have a significant effect in complications, and delayed in enteral feedings in both sets did not seem to affect the time to full feeds. And so it didn't seem to have any harmful effects. There was also a more recent study by Chang, which was a pilot retrospective case study in Florida, performed in Florida, that showed no evidence of increased systemic inflammation when they looked at interleukin inflammatory markers, and there was decreased time on TPN, decreased time to full feeds, decreased hospital stays, and there was no significance on brain MRIs, and we have not seen complications with feeding our babies at that 24-hour mark. Now, it's important to recognize that there are sort of starting to be there's more studies looking at HIE and feeding and initiating feeds in babies. So throughout sort of, we know because we're holding off feeds, we need to provide positive oral stimulation whilst the babies are not orally feeding. And because babies who have suffered from a brain injury are often need more supportive feeding strategies. Just like a preterm baby, they need to be swaddled with feeds, they need side lying, they need their head elevated, and they sometimes need pacing. Because they have altered tone, they have seemed to have sometimes a weak or disorganized suck. There can be coughing, choking, pooling, sort of a loss of bolus, and an inability to sort of handle sort of secretions. And actually a recent study from South Africa from a speech-language pathologist reported signs of what they describe as oral pharyngeal dysphagia. So in 25 of the 28 patients, and 15 of those patients had mild HIE, 11 of them had moderate, 2 had severe HIE. They showed signs of feeding difficulty, and there was and oral pharyngeal dysphagia. And so these signs were falling asleep during a feed, visible oral secretions, this coughing, nasal flaring, and an absence of frequent swallows. So they had a sort of a single suck, as opposed to sort of those kind of burst sucks. So really, really important that we consider maybe OT or speech language therapist and refer to them, and are really sort of aware when we're sort of initiating feeds in our families that the babies aren't going to get into trouble, because addressing feeding problems very promptly with support of these trained therapists may really help avoid feeding struggles and oral aversion, and that can sometimes jeopardize the parent-infant relationship, because feeding difficulty, especially when you're at home and you're alone and you're still recovering from the trauma of having your baby have a brain injury, can be very difficult and have really frustrating challenges for families. And so really important that we are aware of that. And many of these patients that were identified with oral pharyngeal dysphagia were medically cleared to feed and go home. So just something to think about. Assessment. So we can't avoid our sort of our ABCs and of course our neuro assessment. And so we have a very targeted neuro assessment performed by the physician and the nurse, and so that they're working collaboratively to minimize handling. So we don't want everybody going in and performing a neuro assessment to the baby, because we know that's going to be super stimulating. So we really want to be sort of mindful, and we want to sort of share our findings with each other. And so we try to avoid too much handling of the baby. Back to the ABCs and the airway and ventilation. And infants with HIE may have respiratory depression from seizures or high-dose anti-epileptic drugs, and they may need the need for mechanical ventilation, and also just as an effect, the reflection of the degree of the HIE asphyxia that they've been through. Gentle suctioning is needed with these little babies, because what happens is the secretions become quite thick. When you cool a baby, they can be sticky. And we also have the baby on a restricted fluid balance. And so just we try to avoid sort of suctioning and don't do it routinely, and just do it when necessary. But just a little bit of care is needed, because this can be quite a traumatic event for babies. So, and we also want to make sure we know that the cooling can cause coagulopathies and low platelet counts and prolonged prothrombin times. So we just want to really make sure that we observe for hemoptysis and bloody secretions and alert the physicians early if we have signs of that. Avoiding CO2, low CO2, so prevents hypocapnia or hypercapnia, depending on which side of the pond you're living. There is evidence that hypocapnia can lead to impaired cerebral blood flow due to vasoconstriction and cellular acidosis, which can also lead to worse neurodevelopmental outcomes. And alkalosis can, and there's a lower seizure threshold with alkalosis. So really avoid ventilation. Therapeutic hypothermia decreases metabolic rate and CO2 production. And most HIE babies have healthy lungs, and so only require minimal ventilation. And we're really sort of pro kind of getting them off the ventilator if we can, because we don't really want to drop those CO2s down too low. In preference for blood sampling, we like to put a umbilical arterial line in there compared to capillary blood gas sampling. A, because it's a painful experience for the baby to be poked every 4 hours when we check our sort of blood sugars and blood gases as well. We know that cooled peripheral blood can have low pHs and higher lactates due to the poor perfusion, and so it can give you a really sort of false picture. But it's important to remember that temperature correction is needed for blood gas machines when you're actually using cooled blood, and it can underestimate the PCO2 by about 10 to 15 millimeters of mercury. So important to consider that when you are sort of analyzing your blood gases. Airway and ventilation management. So again, we really want to sort of try and prevent hypoxemia, which can lead to further neuronal damage and white matter injury, and avoid hyperoxia. So increase oxidative stress with that, and free radical production, which is associated with death and poor long-term outcomes for neonates in HIE. So really important that we keep between that range of 90 to 92. Understandably, some of our patients, when they've been distressed, will show signs of persistent pulmonary hypertension, and we can use treatments like inhaled nitric oxide to sort of help correct that. But we do still want to sort of avoid that sort of hyperoxia, though we may have slightly higher acceptable values up to sort of 98%. Cardiovascular the cooling actually prolongs the QT interval, and so bradycardia is quite common in these babies. As I said, the heart rate can sometimes go down to sort of the 70s or 80s, and so really sort of important to recognize if your heart rate is kind of sitting around the 110 range, then maybe consider, is the infant in any kind of distress, or is there a sign of infection, or kind of even a kind of a seizure? So be sort of attentive to sort of the parameters and the expected normals that you're going to get with your babies that are being cooled. Cardiovascular instability is common in HIE babies, and we know that hypertension can be a secondary cause to ischemia. So really important to kind of look at our cardiovascular parameters. But we know that blood pressure measurement is often a poor indicator of cardiac output. Fill times are difficult to monitor because the baby's cooled, and so sometimes they're extended, but anything greater than 3 would be a bit more of a concern. Our urinary output can be compromised because your kidneys might have taken a little bit of a hit, and so we like to look at our lactates. And we're a little bit more lenient with our target BPs. If they're greater than or equal to about 30 to 40, then we're not sort of too concerned. And looking at sort of other sort of diagnostic techniques, like looking at an echo, using an echo to look at cardiac function, is sort of a more reliable reflection of cardiac muscle functioning. And an ECG, we can also kind of like monitor troponin levels, so that will give an indication of that myocardial dysfunction. And just when we are warming babies, we realize that they go into that kind of possible vasodilatory phase, vasodilation with that warming. So we're just kind of a little bit more attentive during those times. Fluid balance, we often will restrict our babies down to about 40 or 50 mils per kilo per day. We have strict monitoring of intake and output. We're wearing all our diapers. We usually put a Foley catheter in, especially if the baby's sort of on sedation, although it can be a risk of infection. So it's not always necessary unless you're sort of in retention. But sometimes babies will go into that syndrome of inappropriate antidiuretic hormone when they've been exposed to an asphyxial insult. And so we just really want to monitor sort of our kidney function and as well. We want to report any oliguria immediately, so any sort of urine output less than 1 ml per kilo per hour. And just really important to kind of include all of those flushes so that we don't overload these babies, because sometimes they'll get extremely puffy because they're just retraining that fluid. In terms of our glucose and electrolyte monitoring, anaerobic cellular metabolism and hepatic dysfunction can lead to sort of hyperglycemia. So you have decreased hepatic energy demands because you've put them into that low metabolic state. So there's a decrease in gluconeogenesis and glycogenolysis. And so recognize that you don't want to sort of also exceed the energy demands of a baby that's in this kind of very sort of subdued state, because then you'll get a byproduct of CO2. You might have to increase their ventilator requirements to get rid of that. So we're keeping the babies kind of just at sort of the minimum sort of energy requirement needs, and in terms of their TPN that they're providing. You want to maintain your serum blood glucoses, so avoid that hypoglycemia. And so for us, it's based on the preceding results. We'll do 2 results greater than or equal to 3 and no more than 2 hours apart. And then we routinely will do them Q4. And so that's why it's nice to have that central line access, so that we're not poking babies and disturbing them. We can just do it without them realizing. We also want to monitor electrolyte for electrolyte disturbances. And so we'll do kind of electrolyte panels. And we do, for us, we add our electrolytes to our TPN at about 24 to 48 hours at birth, once electrolytes and renal function have stabilized a little bit. And we add phosphate early on to utilize intracellular glucose consumptions, which decrease secondary energy failure and prevent that exaggerated hypoglycemia. So we kind of really balance that. So it's important to add phosphate into your parental nutrition. Infection prevention, always important for most babies, and most of our HI babies. Most of HIE is not really related to sepsis, but all babies diagnosed with HIE get managed in our centers with a partial septic workup, and they receive empiric antibiotics for early onset sepsis for a minimum of 48 hours. Because a lot of these babies will have central lines in, urinary catheters, and possibly an invasive airway. So we want to protect them. Strict hand hygiene is needed at all times. And the drugs of choice for us are ampicillin and cefotaxime. We avoid gentamicin just because of that nephrotoxic and ototoxic kind of elements. And we know that the clearance in cefotaxime is better for our infants with renal dysfunction. And when we know that renal involvement in 50%, there's renal involvement in 50% of perinatal asphyxial cases. So it is a preferred agent for us. I know some centers do gentamicin, and they'll do a 36-hour ordering for that drug, but we tend to avoid gentamicin if we can. And tools. So the next thing on our list is using sort of appropriate tools to help us with our assessment. So we do routine pain assessment is really important. And you've got to use a reliable sort of validated tool. So we actually do use the NPAS tool, so neonatal pain, agitation, and sedation scale. But it's important to recognize that sedation makes it can be hard to assess when you've got an encephalopathic baby. And so we want to think about just attending to the patient's needs, and if we think the baby might be in pain, or if we're performing a painful procedure, then really kind of attend to that sort of early on and anticipate their needs for pain medication. And we do a Q4 pain assessment for our babies, just to kind of really monitor that and keep them in that calm state. The infant with HIE, especially that mild HIE, can demonstrate that hyper alertness and have a really low threshold for stimulation. And so we got to be vigilant about our pain management and stress during and after procedures with multimodal measures, things like facilitated tucking and containment, and that positive touch and non-nutritive sucking. Just having that maternal sort of presence or paternal presence there, and even remembering that maternal smell is so important in kind of really sort of helping to stabilize and helping to support the baby. And the role in sedation is also there to sort of reduce activity that may sort of elevate the baby's body temperature and impede the goal of therapeutic hypothermia. So and studies have shown that shivering can elevate stress and undermine the neuroprotective benefits of hypothermia. So studies in asphyxiated piglets that were cooled and not sedated had higher cortisol levels. And we know that corticosteroid release during stress can further lead to energy depletion in the brain, so making it much more vulnerable to seizures. So it's so important that we tend sort of our baby's kind of needs there. Pain and stress management. For us, we use morphine, and so opioids are there to kind of blunt that stress and metabolic response during sort of hypothermia. And we use kind of low dose morphine. There have been studies by Freymaier that really looked at morphine clearance, and they recognized that it's markedly lower and could be up to about 50% decreased clearance in babies that are cooled. And so we do use that for a very low dose because we know that can achieve an equivalent dose of about 30 to 40 mics per kilo per hour in babies undergoing therapeutic hypothermia. And morphine, there's been extensive studies on it, and so we felt that it was a safer drug to use in a short term, and so it's only we do use it for the 3 days, and 3 days that the baby's cooled, and then stop it just for that rewarming phase, because we do know that when we start rewarming them, then they may be metabolizing the morphine more readily. Again, we know that it's been proven to be effective and reducing that shivering, and that is one of our goals too. Fentanyl can have less side effects than the morphine, so it won't affect your blood pressure as much, so reduce hypertension, and also doesn't seem to suppress that respiratory effort as well. But we do know that morphine, there's more risk, the fentanyl, there's more risk of tachyphylaxis, so then sort of just getting a tolerance of that. And so we just avoid that for now in terms of using it on our babies when they are being cooled. And then there's some studies with dexmedetomidine, and I know some students' units and animal studies have shown that it could provide a degree of neuroprotection, reducing cellular apoptosis, so that sort of cascade that begins. But as we thought there was sort of no sort of real long-term studies, a recent study by McAdam did show that there was a rise in plasma levels in cooled newborn babies that was kind of very, very slow. And so it wasn't kind of really reached until about 24 hours, sort of after that 18 to 24 hours. They suggested using a loading dose, but we know that the side effects of dexmedetomidine can be bradycardia or hypertension. And right now, our neonatal neuro special interest group, which we have for Canadian benchmarking and best practice, felt that there was limited pharmacokinetic studies on the effects of dexmedetomidine in cool babies. And in a child that was already exposed to a brain injury, we wanted to really see more studies looking at the long-term outcomes for infants. The other tool that we use is a skin assessment tool. So we use the Northampton neonatal skin assessment tool. And we do this as a Q4 assessment. And so our team marks and then continues Q4 assessment throughout the duration of our therapeutic hypothermia treatment. Breath asphyxia triggers that diving reflex, and blood is kind of shunted away from the skin and the splenic bed, so that protect the heart, the brain, the heart, and the adrenal glands. And so we know that skincare is really, really important in these babies. We assess all the skin surfaces that are in contact with the cooling blanket. It's Q4, as I said, and we also have to recognize that sometimes babies get skin breakdown underneath their ECG little caps, little leads that we use. We use little cups, especially if the babies have had a traumatic delivery or instrumental delivery. You get brain swelling, you get bruising, caputs, and that's typically kind of the presentation. And so we have to be sort of really cognizant that we're not getting breakdown on the scalp as well as sort of other areas of the surface. We do position changes every 2 to 3 hours to prevent discomfort and prevent that skin breakdown. To just reduce the pressure really sort of on pressure areas. And that can simply be done by just by tilting the baby. The baby is sort of nicely contained. We have a blanket that sort of wraps right around them. And so that sort of provides comfort and containment, but it allows them to be kind of moved a little bit easier too. We can kind of tip them one side and then the other and take the pressure off, and are able to provide that sort of gentle care so it's not really overstimulating them. And recognize that we want to give some kind of pre-medications if we are performing sort of procedures that are going to be painful. Again, we talked about those kind of soft boundaries, and we also, I think I forgot to mention it earlier, but we do encourage like holding during hypothermia with our families. So we're moving the baby out to the mum so that we can kind of promote that sort of bonding and give them the opportunity to be close to their babies. And so that kind of changes sort of their position and puts them sort of super close to their mums as well, which is super important. We will do that with stable babies, so that when they're physiologically stable, for those babies that are on high frequency oscillation, in pulmonary hypertension, on inotropes, if they have like peripheral art lines, we tend not to move those babies out. But for those stable, so those sort of HIE sort of stages 1 or 2, the babies aren't ventilated, we will kind of give the opportunity to be with mum, and just being able to kind of move them around a little bit kind of is actually sort of protective for their skin as well. And the wrapping blanket that we use allows us to do that. So subcutaneous fat necrosis. So this is kind of often described as kind of firm nodules and plaques that are overriding sort of mainly the bony prominences. And you can see it on the buttocks, the trunk, and sometimes even on their little cheeks, if they're sort of where their head is lying. It usually appears in about 6 to 10 days of life, which is interesting because these little ones may have been sort of discharged at this point. But I will say it commonly happens in those babies that I've found, and in the literature it seems that babies have more sort of kind of severe sort of HIE, because we know that subcutaneous fat necrosis is that HIE increases that risk of subcutaneous fat necrosis, not the actual cooling. And that's been evidenced by other therapeutics hypothermia studies where they've just used a cool cap as opposed to full body cooling. And some of the other sort of risk factors that have been shown for subcutaneous fat necrosis have been maternal diabetes, and so that you have a very large for gestational age baby, so they have a greater adipose tissue and fat stores there, hypertension in mom, and preeclampsia, and really just neonatal asphyxia if there's trauma at the delivery, shoulder dystocias, meconium aspiration, macrosomia. So these are all the babies that sort of tend to be sort of large dates and get into complications with the sort of extraction. And also the use of inotropes has been indicated and in kind of being a risk factor for subcutaneous fat necrosis. Complications from that, the literature sort of says that it's not painful, although we have had babies where it does look extremely painful. It is thankfully pretty rare, but it can cause sort of scarring, and one of the sort of complications is hypercalcemia. So really important to monitor sort of calcium levels. Even sort of when they go home, sometimes they'll have an outpatient to follow that. But as I said, it's more attuned to and more sort of reflective of the degree of severity of their hypoxic ischemic encephalopathy. The other thing the last thing on our HIBERNATE list is looking at the EEG. So we in our unit at a training program So that we taught our nurses to apply our EEG leads. We do have support from our EEG technicians, but it wasn't 24/7. And so we recognized that trying to apply the leads as soon as possible was really important for our babies, because we know that 80 to 90% of seizures, even status epilepticus in the newborn, is subclinical. And so we just weren't seeing it. And so then in order to sort of serve our babies right, we wanted to be able to kind of get that prompt initiation. We taught our nurses like strategies to optimize the EEG tracing. So then when our epileptologist was kind of reviewing the tracings, they had a really sort of a really great tracing to kind of view. We do impedance checks every 6 hours. And then there was continuous sort of observation of the EEG by the bedside nurse, so that they've been taught to flag any sort of suspicious events. They know when the abnormal pattern will kind of revert back to sort of a normal sort of continuous pattern. Again, we talked about recognition of that sleep-wake cycle, and so that kind of it can really sort of affect when they sort of go in for care, or when people come to assess them and say, you know what, the baby's fast asleep at the moment, could we wait kind of 20 minutes, because we know we have a sleep-wake cycle lasting about every sort of 20 to 40 minutes. So in that hour, we'll have one. And then really sort of allowed us kind of have early kind of seizure detection, so that we treated seizures appropriately. And so in our sort of very own sort of research study by our neurocritical care team here at the Children's Hospital, we found that we took our research following our training program on the application and interpretation of continuous video EEG, that there are improvements in the time of initiation of the EEG monitoring, which went from 39 hours to 7.5 hours. So we got those monitors on really, really quickly. So the availability of brain monitoring for all our infants, irrespective of the time of the admission, ensured prompt management and accurate diagnosis of seizures, which actually resulted in a significant decrease in the need for anti-seizure medications. So we had more babies being discharged home not on anti-seizure medications. So it went from, so those discharged home on meds went from 70 to 37%, because we know that before we were possibly misdiagnosing abnormal movements as seizures. In animal studies, phenobarbital and phenytoin have been shown to actually induce apoptosis in rat brains when developing neurons are rapidly growing and trying to establish those synaptic connections. So we know that anticonvulsants aren't a good thing if you don't need them. And so it is neuroprotective to be able to recognize when you really need to use them. Our mortality rate dropped from 12.5% to 5.4%, and significant brain injury on MRI went from 42% to 18%, and our babies went home earlier. So overall, the training of our nurses to place those leads with expert support from our EEG technicians. They would come in the morning and just tweak, maybe add a few leads, maybe sort of look at a different sort of area of the brain if we hadn't caught it in the basic montage that we had put on, and just helping us sort of optimize a good signal. But it just allowed for better interpretation by our epileptologist, along with the guidance of our neurologist, in terms of the management and prognosis. And together with our incredible team, we've developed this neurocritical care team that allows us to provide our families and their infants with the best quality of care. So important that we get that early sort of ability to put it on and really sort of know what we're looking at and know what's going on inside that little one's brain. So then, as my final thoughts, we have a small window of opportunity to support our parenting skills and prepare families for a journey often still filled with that uncertainty. So we need support, communication, and teaching are vital sort of in those kind of few days, possibly that 7 to 10 days that the families are with us. And that a focused neuroprotective nurse care can really make a difference in the neurodevelopment of our little ones with HIE. I just wanted to quickly say, if we've got time, to do a very quick case study. We had a little girl, she was 38 weeks, her girls were 1, 1 and 4, her core pH was 6.8. She had severe hypertension. She actually did receive saline, blood, inotropes, so some of the things we like to avoid so that we don't overstress the body, but she received them. She was ventilated for 7 days, so and she also got severe hypercapnia. Sometimes it's difficult to control because she's hyperventilating, but needed that respiratory support, and did actually suffer from hyperglycemia. Clinical staging actually was moderate to severe HIE, and on EEG, this is what it looked like. So a burst suppression image on her EEG. Her MRI, her MRI was, for those of us looking at it, just to know that the bright spots on the MRI show the areas of injury. And this was reported as a brain with total asphyxia. And this little one, unfortunately, was given a very sort of grim prognosis. But this is her at 2 years old. And so just amazing to see how this little one has gone, and a very brief clip of her at 2.5. So I'll cut it off there, but it really just wanted to prove that neuroprotective care and very focused nursing neuroprotective care can really, really make a difference to these little ones' outcomes, and really help that neuroplasticity, and supporting those families. And this family was so supportive of their little one that they really helped her outcomes. So we never want to give up hope. Thank you.
Thank you very much, Jan, for this comprehensive and thorough presentation and approach to babies with HIE, not like being tunnel vision on the brain itself, but rather being like encompassing all organs and thorough care. I will I think we have about like 7 minutes. I will pick up few questions from the questions we got from the survey. And then if we have time, we can pick up some questions from the chat box. So
sure.
There were like 3 questions kind of asking this similar thing about the applicability of this approach in low to middle income countries. And if you have some recommendation and advice for centers that they don't have advanced resources.
Well, definitely. And I think just from the talk, it's totally feasible, because a lot of what we're doing is just really neuroprotective care is developmental care. And so just those sort of basic strategies, the importance of having a family presence there, the importance of providing sort of containment. And there's sort of many developmental care programs from Alston's active theory of development to the neonatal interactive development care model that really just kind of look at improving neuroplasticity, enhancing developmental care. And those strategies are simply keeping neutral body alignment, providing sort of that nurturing environment where you've got dim lights, where you've got quiet noises, appropriate conversation. Really just important to recognize that families can be in there, they can touch their babies, they just teach them how to provide that neuroprotective care. And so all of these strategies go a long way to actually stabilizing and giving that neurostability to these little ones. So those are things that anyone can do. So you don't need to have the, it's great to have all the monitoring techniques and have a full neurocritical team, but you can make a huge difference in just that very intentional nursing care and that teaching of those families for the long-term outcomes.
Great, thank you. And there was one question also about the use of melatonin as an adjunct therapy for therapeutic hypothermia. What are your thoughts about it?
There's a lot of research out there, but if we were to pick, I know our team, if we were to pick one drug, then that would be the most promising drug, because we don't know that melatonin sort of enhances sleep. And we know that recovery to that sleep-wake cycle shows us that reorganization of the brain. And so this drug sort of makes total sense. And we know that as adults, we kind of take it for sleep disturbances. And a sign of a healthy brain is that recovery, so that even babies with mild HIE, if they don't develop that sleep-wake cycle, it can be a sign of poor neuro outcomes. So this, if we can enhance sleep and we can have that brain, give that time a chance for reorganization and healing, I think it would be beneficial. So that's something that we are looking at, and just looking for sort of more data to come out. I think there's just one study from Egypt right now, and so, but it is something to think about.
It's great, thank you. And there were a few questions about your practice in terms of like anti-seizure medication and seizure management and monitoring, if you can comment on that.
Oh yeah, so I didn't sort of go into sort of drugs in in the protocol, but in terms of sort of our kind of treatment, we tend to use, if the seizure is brief and infrequent and subclinical, then we will treat with high dose Keppra. So that's kind of our sort of a standard here. If it's frequent, high voltage, and long in duration and electroclinical, then we tend to give a loading dose of phenobarb, and then, excuse me, and if that is effective, then we'll follow up with Keppra as a sort of a maintenance. If you're still getting breakthrough seizures, then we tend to continue with maintenance phenobarb until those seizures have stopped. But we've really sort of got away from, once we've got control of the seizures and we're not seeing them for 24 hours, we'll discontinue the AEG 24 hours after the baby's seizure free, and we are not really discharging babies home on sort of those maintenance anticonvulsants anymore, and so we can usually get on top of them while we're in the hospital. Yeah.
Thank you. And there's a question also about the impact of the COVID-19 situation on the family integrated care, and some of strategies that you have adapted to kind of mitigate that problem.
Right. Yeah. I mean, luckily we haven't really experienced. We have had babies sort of precautionally on for query sort of COVID-19. But of course, we've had to implement sort of different strategies. And yes, that's been a sort of a real challenge, because we've limited our visiting down to one parent. Sort of the irony of that is, I find, is that because parents have been told they're limited and only one person come in at a time, they tend to be doing shifts, and so they tend to be sort of swapping out. And so the families tend to, because we're just encouraging them not to sort of come and go just because of the risk of infection, so they tend to be staying all day long, and which is great because they can really get involved in the care. There's a lot of teaching going on. The staff have really been sort of involving them actively in the care of their babies. And so we've actually been able to implement sort of better family-centered care and our families have really been becoming involved in sort of rounds and kind of reporting, because they're here a lot of the time. So it has worked to our advantage in some ways. So that's been sort of a one plus side. We've also kind of done kind of Zoom meetings for parents, or starting Zoom meetings just for parents to sort of collaborate together and give support to each other and sort of share their stories, which helps them in the unit.
So a last question, I'll leave you with this question and see what's your thoughts on it. Like there has been two questions from the chat box regarding the case you presented. Like how come, despite having all the risk factor that we are trying to avoid and terrible MRI, this baby turned to be normal, and she was, if I remember right, she was discharged early actually from our
Yes.
neonatal follow-up clinic, because they didn't need to follow her in any aspect of her outcome, and she's like about 5 years now, and she's doing great. So how come, how come this brain has turned around as compared to others? So some of your thoughts on that.
I truly believe it is about the neuroprotective strategies that we provide, and that sort of interaction with the child and maintaining that protective environment, and keeping them calm. And this family was extremely involved in their child's care. Mum was very present, would be involved in everything, would read to her child, and we kept them very positive and very hopeful, and really sort of encouraged them to believe in that all of the strategies that we provided would really enhance that neuroplasticity. And they were very, when they took that child home, they were doing that interactive reading. They were very proud that they were really trying to establish and optimize the potential outcome for their little girl. And we, when they came back to visit, we told them we were just extremely proud of them, because obviously all of these strategies and just believing that your child and not treating them like they have a brain injury can go, I think, leaps and bounds when you have low expectations of your children, that they kind of live up to it. And so this family was determined that they would give her a best possible chance. And it is my true belief, despite all of the things that were thrown at this little one, despite the fact that we had her on inotropes and that our CO2s were low, we were able to kind of support and provide neuroprotection in some way. And I believe it was down to the team's sort of handling and the care and the parental presence.
Well, thank you very much, Jan. We could feel your passion throughout your presentation. This has been fantastic. Thank you everyone for joining, and I hope we will see you next Thursday with our AEG talk.
Thank you so much for the
Thanks.
opportunity.
Thanks, Jan. Bye.
Thanks. Bye-bye.